All right, good morning, everyone. It's my distinct pleasure to introduce our visiting speaker this morning. Dr. Vivian Yin is a clinical associate professor at the University of British Columbia and practices ophthalmic plastic and reconstructive surgery. She did her medical school here in Toronto, yay, and her residency here in Toronto as well, after which she did a prestigious 2-year ACE Offers Fellowship at MD Anderson in Houston, Texas. She practiced at Memorial Sloan Kettering Cancer Center in New York, returned to Vancouver in 2019, and where she's been practicing since. She has research interests in periocular and orbital oncology, as well as thyroid eye disease. If that doesn't keep her busy enough, she also has a master's in public health from the Johns Hopkins School of Public Health. She generously donates her spare time towards eliminating preventable blindness and has traveled to Bangladesh, Philippines, Nepal, Tunisia, and India. She's the current chair of the Canadian Association for Public Health and Global Ophthalmology, and the COS representative to the International Council of Ophthalmology. And she's the chair and member of the board of directors for CEVA Canada for 6 years. And so it's a great pleasure to welcome her back home, and we very much look forward to your talk.
Thank you, Dr. DeAngelis. I'm gonna try to stand here in case my voice drifts in and out. But can everyone still see me on the camera, Amandeep?
Yes, yeah, we can see you. If you could just be a little louder, that would be better.
Okay,
Sorry.
I will. If my voice drifts, just give me a little hand signal of some sort.
Sure.
So thank you very much, Dr. DeAngelis, for inviting me back. I was here to give grand rounds, I think, I looked it up, I think 7 years ago, when I was early in my career. And it's a pleasure to be back here because this is my home and my alma mater. And I still have very fond memories of everything in Toronto, although it's changed a lot every time I come back. So since we're getting a late start, I'm gonna get going. So I've been asked to talk about biologics. I sort of reframed it a little bit because biologics sometimes is a term that is used differently depending on who you're talking to. So I thought let's just make it a little broader and saying, how do we go beyond surgery in managing periocular and orbital disease? So the first, no, my clicker is not working. So when we ever, as a surgeon, talk about getting out of surgery, it's always like, are you out of your mind? Like we live and breathe surgery. We're a surgical specialty. We operate. We love being in the operating room. This is the guy who is keeping me kind of off the speaking podium the past 2 years. So those of you who know me, this is my son, which was a surprise to everyone. And he has a lot of facial expression that's very interesting, even though he's only 1. So I do have some financial disclosure I have to talk about. So I am a co-PI for Sling Therapeutic, and some of these companies are the companies that are investigating drugs in thyroid. I don't receive a dime from them. I'm a co-investigator, and the money all goes towards the clinical trial site. So not a real direct interest. I will be talking about some off-label use of drugs, so be aware, and I'll try to talk about some of these off-label use and highlight them to you. So for today's objective, I really want to just focus on 2 things. The first half of the talk, we'll really be talking about specifically the management of thyroid eye disease and non-surgical management of thyroid eye disease. And there are 3 major categories that we should think about in terms of drug therapy. And it's the famous IGF-1R blockades, the IL-6 blockades, and of course, our old friend, the corticosteroids. And then we'll switch gear a little bit just to touch very briefly on the other aspects of orbital and periocular disease that require a lot of drug therapy, which is oncology. And we'll talk a little bit about targeted therapy and where that is, a few updates on where advances in that field has been. So thyroid eye disease really has exploded, I would say, since Tepezza, which is the big drug, or teprotumumab, got approved by the FDA back in 2020. And since then, I would say you're going to see endless number of advertisement slides, and just be cautious that most of these are pharmaceutically sponsored, and because there is big monies to be made by them. Just to remember that each of these vials of what's approved is almost $15,000, and that's 1 single dose. So this is a big, big industry, and I think in the next 5 years, this is kind of the cusp of drug therapy exploding in oculoplastic, and we were always the orphan child when it comes to pharmaceutical company. I think for the first time, now they're knocking on our doors, and I think as members of CSOP, the Canadian Society for Oculoplastic, we're starting to learn from our retinal colleague, how do you interact in an ethical way with pharma companies? Not only is the pharma companies interested in this, there's actually a massive explosion. Explosion of publication, even just investigator initiative, as well as just review articles, commentary. The number of publication is just skyrocketing. You know what? I just noticed something. Sorry, I'm gonna pause for 1 second. Now, you can't talk about thyroid disease without first defining what it is. So the diagnostic criteria for thyroid eye disease actually was first proposed many, many years ago in 1994 by Bartley et al. You might know George Bartley, he's still alive. He's the president of the ABO now. And he kind of thought about it in 2 categories. So you either classify people based on those with eyelid retraction, then a slew of other factors, or you think about people with thyroid dysfunction plus other factors to kind of make the conclusive diagnosis. But the honest truth is, at that point, they thought no cause is a single apparent cause. And since then, the diagnostic criteria has really been shifting. People are thinking about the disease differently and recognizing nuances about it. In the most recent NASO's meeting, they actually are trying to come up with a diagnostic criteria where it can be used more universally, both by endocrinologists as well as ophthalmologists. And this is their proposal. We'll see how far this goes. But the bottom line is the definition of thyroid eye disease, unfortunately, depending on who you talk to and which continent you're on, does vary quite a bit. The other thing about thyroid is we know that it's actually a dynamic process. Not only is it a heterogeneous disease, it's also a disease that changes, depends on when you catch the patient. And the famous Randall curve that we know about talks about how the disease worsens in the first 9 months to a year, and then gets slightly better. But how much better, how much worse, is really highly variable from patient to patient. And they can look very different. They can look barely anything at all, like this bottom right, where it's like you can say that patient just didn't sleep well the night before, to the bottom left, where that's what you think about when you Google thyroid eye disease on Google Images, someone who is very proptotic, very swollen, etc. I'm not going to go into too much the pathophysiology of the disease, but we can talk about that more at the resident lecture if you're interested. There's still things that are unknown about the disease is what I'm going to say. So what is currently available? So I mentioned there are 3 major categories. So IV methylpred or corticosteroid is still our go-to or mainstream or standard of care, however you want to think about it. There's tocilizumab, which is an IL-6 blockade, which is a drug that's currently available because it's a drug that is used for rheumatoid arthritis and GIA and a bunch of other rheumatological conditions. There's rituximab, which I won't talk about too much right now, partially because the evidence for it or against it has been weak. There's small case series that are investigator initiated compared to some of these other drugs that do have randomized clinical trials to support them. And then of course, the most famous one is teprotumumab, which is Tepezza, the brand name. So as I mentioned, it's approved in January 2020. It's a monoclonal antibody, so it's an infusion against IGF-1R receptor, which is part of the pathway for inflammatory propagation of fibroblast differentiation. And it's approved for, very broadly, treatment of thyroid eye disease. There's actually no specific categorization or more details beyond that with the FDA approval, which is what led to, I think, a lot of confusion as to when do you use it? How do you use it? How long do you use it for? And a slew of questions that's now starting to be investigated. It is dosed based on weight because it is an infusion. So the classic dose, which is what is FDA approved based on the initial landmark study that we'll go into, is 10 milligram per kilogram as an initial starting dose. then up to 20 for the second dose and subsequent, with a total of 8 total doses 3 weeks apart. Okay. So what are the studies that supported its approval? There are 2 landmark studies. This is the first one, and it is a double-blinded, randomized one-on-one. It's on the New England Journal of Medicine, and it's really hard to critique this study aside from what metrics they use to monitor these patients. And the reason for that, I'll talk about in the rest of the lecture, is that there are different grading systems or different scoring system for thyroid eye disease. And depending on which use, different people who treat thyroid a lot will argue that one scoring system is not as good as another for monitoring disease, and you're not getting the full picture of this very heterogeneous population of patient. But by and large, most of the clinical trial now for thyroid, unfortunately, is still relying on CAS score, which is a very straightforward 7-point scoring system, which is why people argue against it, that it really doesn't show enough granularity on the improvement of patient. And when this study first came out, I have to say, I kind of shitted on it as well. I also thought, based on the primary outcome, where just 2 millimeter of proptosis reduction, that's really not enough. Like, that's not enough to get someone who is extremely proptotic into quote unquote normal. And because of that, a lot of people still have to have surgery. So what's the point of giving this really expensive drug for a long period of time with potential side effect when you're not really going to eliminate surgery, which we know works so well. So they also looked at some secondary outcome, which is CAS score reduction to less than 2, which is what the definition most people use to say that they are now inactive. And then they looked at a couple of measurements in terms of diplopia reduction, et cetera, and some quality of life measurements. And this is what they looked at, or this is what they found. Now, it's a busy slide, but I find it's easier to just go through a table together rather than trying to write a million bullet points of what the results actually are. So first column, of course, is our investigated drug, tepalizumab, and then your placebo patient. And the ITT means intent to treat. So whenever you look at a randomized clinical trial, that's the first column, the first line you want to look at, because you really want intent to treat. Otherwise, if you do investigator observes, or it eliminates the whole purpose of doing a randomized blinded study. So when you look at intent to treat, the TPO group, in terms of getting an outcome in proptosis response of 2 millimeter, you see 82% instead of 10% in placebo. So it looks amazing based on these numbers, right? Keep in mind, it's 2 millimeters. That is the primary outcome. The other thing is that is of concern for those of us who treat a lot is double vision. Because the proptosis actually usually doesn't bother the patient that much. I have patients who are hugely proptotic and retracted, and they're like walking around town saying they don't want surgery. The diplopia, though, is what actually makes people become suicidal. And I have patients who I have to refer to psychiatry urgently. And this is what actually really impacts their quality of life way more than proptosis or the retraction. And you see that that difference is still statistically significant, but starting to become a little less dramatic compared to proptosis reduction. So 68% of people had a reduction in the severity of their proptosis, diplopia. They did not talk about how many people still gone out to get surgery. So that's still a unsure portion. Now, behind the scene, when people who did participate in these studies did talk about it, and the truth is a large percentage of people still need a surgery when you talk to them one-on-one, saying, what truly happened at your center. What about the total change of proptosis, the mean change of proptosis? So instead of just saying the percent of people who reduced by 2%, what is the actual average or median reduction in proptosis? So we're looking at 3.32 at the end of the follow-up, which is 24 weeks. So still, we do a decompression just medial wall and floor, we get 5 millimeter easily. So what is this really doing for us clinically? And I think that's a question that we still don't have a clear answer to in terms of when is the optimal time to be using this type of drug. Now, later on, I'll talk a little bit about, unfortunately, tepalizumab is not available in Canada. So I can talk to you about the study, I can talk to you about my interaction with seeing other people's results, et cetera, but I can't tell you any of my personal experiences. So I'll tell you what our personal experiences with using some of the other drugs that is available in Canada. This is a second study that was quoted by the FDA as a reason for approval of this drug, which I only highlighted 3 things to you because the study design is very similar to the prior. but the N is 37. So it's very shocking for me that FDA approval now is allowing articles that is only 37 patients to when most of the pharma studies for other drugs in internal medicine, we're talking about thousands of patients in magnitude. But I think they're just looking at this as a extension in terms of the other study is really the reason why they base their approval on. Sort of similar results you're finding even at the extension. What they're trying to show is, was there any regression of the treatment? And based on this published study, they're claiming there isn't really a significant reduction. And the bigger point for the pharma company for doing this study is that they want to show retreatment of those who did not respond initially, whether they were in the placebo group or in the treated group, continue to respond more. So this really is trying to show two things. One, if after the 8 doses that they did not improve as much as you want, you can treat them again for even longer. So now in the US, what people are doing is patients are sort of on this drug almost indefinitely. Does that remind you of something? So that's where Avastin and Lucentis ended up, right? So now they're in this perpetual endless injections and sorry, retina colleagues, because I'm not a retina colleague anymore. So to me, it just seems like this endless lifelong injection. And the question becomes, is this going to become an endless lifelong infusion for some patients where they get infusion every couple of whiles, et cetera? Now, I don't think it truly will go that direction because we know thyroid eye disease eventually burn out, whether you treat it or not. Eventually, it doesn't matter how long. So probably this is not going to be as long of a duration, even if with extension study and retreatment schedule in place. And then the other thing they want to show is that even those patients that were in the placebo group who are now 24 weeks beyond their initial treatment point, because the other thing with thyroid disease and this drug is that theoretically it should only work when the patient is still active because it's targeting the inflammatory cascade. So once the patient becomes chronic or inactive, which happens anyways, it shouldn't really work, right? Theoretically. But they're trying to show that for some strange reason, it still works. And this actually led to subsequent studies that are now looking at chronic thyroid eye disease. So those that were labeling as inactive and whether treating with this drug also still give them improvement. So some clinical example shared with me by some of my colleagues in the US, and I'll show you 2 different examples, 2 different style, 2 different surgeon. This one is from Dr. Kahana, who is a big person in the US, an ASOPer and kind of founder of NASOS, who is very pro these drugs, all of them. He works with all the pharmaceutical companies, so at least he's not biased to one drug. So he's showed this case with me as a responder, so someone who has a good outcome. Elderly lady, came in very hot, very swollen on the left. After one single infusion, already sees clinically, you don't need even numbers. You can just subjectively already see that this patient has improved. And then after 3 infusions, remember the total is 8, so this is not end of treatment. She almost looked normal there. Okay, so this is what got people really excited of the drug for those who were part of the clinical trial. Canada was not for the initial studies. Now, I asked another colleague of mine who I know wasn't in one of these positions to be consulting for multiple companies to say, can you share me a real life example of a frustrated patient that's on teprotumumab that you have treated and what happened and why? So this is a lady of his who baseline had very proptotic and a lot of liver retraction, 24 and 20 measurements on Hortel. I did not give you the base here only because the base is the same across the board. After 8th infusion, he did not give me any interval photos of her. Significant reduction in proptosis, 21 and 20. Now she looks semi-normal. Now, one will argue at this point, patient probably, if they're willing to take a drug like this, will still want surgery because she still has liver retraction. She doesn't look, quote unquote, normal. But what's interesting about this case is 11 months later, she relapsed back to her original measurements. So one of the things no one is talking about for those in the US who are big, and there's about maybe a dozen people who are centers that are using this drug a lot, like putting everyone on it. They never talk about relapse unless you ask them point blank. So when you ask them point blank, do you see patient with relapse? Oh, yeah, but you just retreat them and then they get better again. So it's like, well, where does it end? So there are lots of other drugs that are in the market that are coming down the pipeline. And I'm just watching the time and I realized I haven't even got through the thyroid part and we're already at time because of the delay. So I'm gonna kind of go a little faster and we can skip the last part of the talk if we need to, because I think this is where people are most interested in. So there's 4 other major drugs that are actually closer to FDA approval, and that's why I'm only mentioning them. The bottom one by Novartis is actually the one that is the furthest, and they're kind of in order of closest to approval. So Viridian is the company that makes the second drug that they didn't give it a name yet, so it still has a code, a barcode number. It is still a monoclonal antibody, but the company tells me that they're actually coming up with an SC trial, so a subcutaneous injection instead, very shortly. And then also Horizon, which is the company that makes Tepezza, is also coming up with an SC injection for ease of administration. Litinsibib is a small molecular also targeting FGF1R. So instead of an injection, because it's a small molecular, it's a pill a day. We are a clinical site for that. And I have to say, totally not analyzed, just anecdotally, what Dr. Dolman and I both feel is that we're not sure it's actually getting the results that we're seeing from the large molecule trials. But we'll see. It's a small number of patients that we enrolled in that trial so far. We do not have Bactoclimat. I don't know why. It tried to come to Canada, and then I think the trial just completely stalled in its FDA, in its IRB. So attempt was made and things kind of didn't quite go as far for Canada, that is. So I'm going to skip the radiation for the sake of time because I think the other is steroid, but just to say that there are clinical study going on, also looking at combination of radiation and steroid, and that may be getting you more effect with diplopia compared to some of these drug therapy, which is the marker that I'm the most interested in order to avoid strabismus surgery for these patients. But we'll keep an eye out. The big study that I keep wanting the results of is the study called CRISPR. Now, some bias is that Dr. Dolman is the driving force behind this, but it is an international eye test-driven study, which also got stalled during COVID. So it's now kind of starting to go back up and running. So it is double-blinded, mass randomized. So it'll be interesting to see what this study shows. I will spend the last couple of minutes before we talk about questions about tocilizumab, which I think this is the other big reason why Dr. DeAngelis probably asked me to talk, is we in Montreal and Calgary are probably the 3 centers in Canada that have really tried to embark on this and push this forward for Canadian population. Partially because it's already approved by Health Canada, and Montreal is the one that spearheaded this, where they really got like a standard thing going where they get approval easily, et cetera, et cetera. It's used in rheumatoid arthritis, GCA, as well as GIA quite significantly. It's a monoclonal antibody against IL-6, which is one of the interleukins that are responsible for the inflammatory cascade. Remember, corticosteroid is more of a blanket thing. It doesn't target one specific thing. It just kind of dampens everything down. So what's interesting in this study, is that it's been used in steroid-resistant patients. So steroid is still your first line, but there is a small subset of patient, I would say 30% or so, 40% just anecdotally, that does not respond to steroid. And in those patients, the European group put them through tocilizumab because it's also approved for rheumatoid condition in Europe. And they actually did a very nice, beautiful, double-blinded, randomized clinical study on the use of this. Now, the original study actually used infusion instead of sub-Q, even though most of us are using the sub-Q injection. But I think the results is similar because it's still a monoclonal antibody that you're using. And they kind of parallel what you see Tepezza do, which is, unfortunately, they use CAS score. And they look predominantly on CAS going to 0, which, again, doesn't help us with the other markers that we're interested in. They looked at the other markers as secondary outcome, and I'll show you what some of those shows. So this is against placebo, okay? So we're not comparing it to corticosteroid. We're saying these are corticoresistant patients that we are treating with either Toci or nothing. And you can see that in the Toci group, there is significant improvement in both the proptosis, sorry, the label's not the proptosis, which is their, not proptosis, CAS score, which is their primary first outcome, which is this first one, less than 2, and then recurrence increase of CAS by more than 1. And you can see that on the first graph, almost beyond 90% of people became inactive, okay, compared to placebo, which is 58%. Now I say, well, placebo is doing pretty well. Natural history, okay? So you have to remember that natural history also get people better. And then getting to 0 becomes a little less, but still 86%, pretty impressive, right? For a drug that is only $300-400 and readily available to us. So this trial kind of got me interested. So I asked Dr. Kayla to come and give grad rounds in Toronto because I wanted to know his unpublished data. So this is unpublished, courtesy of him. And the thing that's most interested in his study is the use of this in patients who have optic neuropathy. He has 6 patients who had this thyroid optic neuropathy, and there's other terms you can use for it. And he got 100% improvement in visual field. Now, what does that look like? This is one patient of his who 67-year-old, steroid resistant, had the thyroid optic neuropathy, couldn't get surgery, visual field defect that normalized after 12 injections. Okay, so I think this is where I think interest for me peaked is on using, and I'll give you one last example and then we'll do some questions. This is my patient, 45-year-old male, non-smoker, thyroid diagnosed back in October 2021. Here is her baseline measurement. Unfortunately, I went on mat leave, so she kind of got neglected, so a little bit, and then she slowly progressed over a period that is much more extended than you would expect. So over 2 years, she slowly got worse and worse and worse with VISA score. So I'm presenting VISA score, and I'll talk about a little bit more about why I prefer that. Slowly increased over time, restrictions slowly increased, initially only on the right eye, then progressed to both eyes. Pretty significant restriction. She had early radiation, and this was back in the days where I give early radiation to anyone who has significant diplopia and restriction. But despite that, still continued to progress. And I always try steroids before radiation. So she has steroid followed by radiation and still progressed. So by the time I saw her, she was miserable, she was depressed, she was crying in my office. And she has 2 young kids, and she literally was like, I can't take care of my kids anymore. I'm literally just crying when I'm seeing them. And they're asking me what the hell is wrong with me. And I'll show you her picture and you'll see why. But after 8 months, which is 8 doses, which is only 2 months, so weekly doses, this one, with the sub-Q injection, her proptosis decreased significantly. VISA score had gone down to 8, okay? Restriction, this is the part that really excites me. The left eye became completely normal. The right eye reversed back to her measurements on 2021 when I first met her. And this is what she looked like after 1 month and after 2 months. Now, the only thing I want you to notice, because she's still proptotic and restricted, is her eyes look straight on primary now. And this is the reason, so I just saw her last week, and that's what the 2 months follow-up was. And she was smiling for the first time and finally like not crying as soon as she see me. So I think this to me is what I think a drug therapy needs to do for patient is actually reducing their strabismus more than the proptosis or the liver retraction. The liver retraction is probably the one that I think is the easiest to fix and is really not a big deal, quote unquote. The diplopia is what really will get people depressed and dysfunctional and disabled. The proptosis will be as a secondary minor cosmetic thing and easily fixable with decompression. So I'll stop there and recognizing that it's 8:01 already and see if there's any question either from the online people or from the audience.
No, I think we're good to keep going, Vivian. Thank you.
You want me to finish the rest of the presentation or?
Yes, exactly. That'd be
You
great.
do?
Thank you.
Okay. It's some. Oh, I thought it was 8. Sorry, that's why I like totally started rushing. My apologies.
No. You've
I thought it was
got till
7 to 8.
8:30. We're good. Yes, thank you.
Okay, so I thought it would be useful to kind of give you some sense in terms of how do I think about each of these drugs, when do I use it, which one is the best. This is very draft. This is not proven with lots of literature behind it. This is really clinical experience based on treating these people with multitude of things. So I think to decrease activity, all of the drugs will work. all the therapy will work, natural history will work. Now, some will work faster than others. So I think tepozilimab, tocilizumab, these drug therapy will work much faster and much more dramatic than you will see with natural history or some of these other drugs. They're also very good for the soft tissue. So lid edema, lid retraction, I think they look well. I think they're very equivocal with EOM restriction. Now, some of my colleagues would disagree with me on that, but to me, resolution or improvement of EOM has to do with no longer needing strabismus surgery. If they still need strabismus surgery or management of diplopia, to me, then that's not enough. And then proptosis reduction, I think with TPRO and TOSI, a little less than what you can get with steroid or with decompression. So I think if you're really thinking proptosis only, I will go decompression and not even try any drugs. So any questions? Because I know there was a question about thyroid, so.
Yeah, thanks for the presentation so far. I actually, in connecting these slides as well, I'm just wondering because Tepezza and some of the newer drugs block IGF-1R and the insulin receptor. Would that interfere with patients with diabetes and cause hypoglycemia?
So excellent question. Good pickup. I didn't even talk about side effects because I already have 75 slides and I don't want to make it longer. So yes, that's a concern. So far in the original studies, patients were very strictly controlled. So no one with poorly controlled diabetes was allowed in the trial. And those who are in the trial had to have their diabetes strictly monitored more stringently than they usually would have. And because of that, there was no significant worsening of people's diabetes. So no one fell out of the trial because of diabetes. Okay, but once again, that's clinical trial scenario. That is not real life practice. I would say one word about side effect, which is that the biggest side effect that people are now writing about and paying attention to is hearing loss. Don't know why. We don't know the mechanism exactly yet. But some of the later studies published by investigators who were part of the original trial with their experience is that hearing loss may be higher than we had anticipated in the original trial. And some of the reported study can be as high as 50%, and it is irreversible. So that's.
Oh, sorry, Vivian. I was just gonna say we've got a comment or question from Nav. I'm just gonna take that opportunity now. Nav, go ahead.
Sure.
Yeah, hi, Vivian. Fantastic talk. I'm sorry I can't be there in person today. I don't know if you're going to talk about this, but my biggest, and I think the biggest thing a lot of us in oculoplastic struggle with is the patients who have compressive optic neuropathy. So I'd love to hear your approach to managing patients with compressive optic neuropathy in the setting of all these new medications.
So I sort of alluded to the fact that I'm very interested in how TOSI would perform in optic neuropathy, especially after seeing Montreal's data. I don't think anyone beside Montreal has been using it in optic neuropathy, but I would say that is not my first line for a couple of reasons. One is, unfortunately, you practice the way your local environment is. Or I shouldn't say unfortunately, fortunate and unfortunate. So I am slightly biased in that I think decompression works really well for optic neuropathy. And I can have an entire hour of case example of reversal of optic neuropathy with decompression even years later. And I would say even my very first patient out of fellowship, like literally 2 months after fellowship, who was blind, literally blind, like hand motion counting finger vision for 2 years, but refused surgery because he's a stubborn Korean man. And then finally, I basically had to sit down with him, with his family all around and basically say, you don't have a choice. You're literally, I will not be able to, like, you're literally going to go pitch black if you don't do something. So after 2 years of vision like that, he is 20/40 post-op. So I think one of the things that I've learned from Dr. Dolman is that for some strange reason, optic neuropathy from thyroid does not behave the way optic neuropathy from other disease. It is highly reversible. to the point where we don't even schedule people in the middle of the night for surgery. Someone comes into me, early optic neuropathy, I'll be like, sounds good, I'll see you in a month for surgery. So it's not as dramatic, I think, as I used to think about the disease. And it is so reversible with surgery. Now, the bigger question is, what if these people are still active? You decompress them, their neuropathy goes away, but they're still active and they're going to continue to progress. I think that is a harder question. You can use steroid to try to dampen them, but the truth is they're still going to be active for, let's say, the next 6 months. You can't really put them on steroid, high dose steroid for 6 months without major side effect. And I think that's where drug therapy comes in. And I think that's where I will start to lean on these other drugs to stop the activity. So what do I do now in my practice when I see someone who is really hot that I'm worried about, high risk for progression to optic neuropathy, which are people like Asians, continuous smoker who refuse to stop smoking, and those are really high antibodies, is I put them on drug therapy, try to dampen the activity without the expectation of getting them out of surgery, but rather to prevent them from progressing to optic neuropathy, and then surgery if needed. And I think that combination before and after, it's almost like what you'll see in the subsequent slides is the same thing we're doing with drug therapy and cancer. So you're almost doing like neoadjuvant drug therapy, decompression for the optic neuropathy, and then adjuvant therapy to prevent them from progressing. Does that answer your question, Nav?
Yeah, no, that's exactly sort of where I wanted to sort of touch base with the residents and everyone, just to get an idea that, I mean, there's still a role for surgery. I guess my other last question, because I want to take too much time up, is what about radiation? Where do you use radiation in compressive optic neuropathy? And do you use it in any patients who are diabetic who don't have diabetic retinopathy?
So I'll answer the second question first, because that one's a short answer, which is the answer is yes. I do use it if they're well controlled, no diabetic retinopathy. The dosage you're using, I think I'm much more comfortable with radiation because I use it so much for my cancer patient that I'm very comfortable with managing the side effect profile. So at 20 gray, which is the standard dose for radiation for thyroid, you're not going to get retinopathy. I'm sorry, you're just not. And any radiation oncologist will tell you that that's not the concern. They're going to get the dry eye, they're going to get an ocular surface. Unless you have like a florid, like ischemic retina, the 20 gray is not going to damage the retina, much less the optic nerve. So the first question you have about where does radiation play? So I would say I use all of them, and it actually depends on 2 factors. One is patient's ability to tolerate side effects from drugs. So drug therapy actually has more side effect than radiation does. So if I have a very frail, fragile, medically fragile patient, I'm more likely to lean towards radiation than I am drug therapy. Now, if I have a younger patient, and we know the younger patient tends to generally be healthier and have more reserve for toxicity, those I tend to use drug more. So that's sort of where I generally lean. Now, it's still a patient decision, so I lay out all the side effects, all the pros and cons, and then see which one they're willing to take. But I would say radiation does work well with stopping activity. So oftentimes what I'll do is if they have bad optic neuropathy, let's say splitting fixation, I'm really worried about them, I want to decompress them right away before they become inactive, I would decompress them, set them up for radiation almost like within weeks after surgery. So usually 4 weeks is the minimum you have to wait before surgical scar heal and then radiation. So I would do surgery, wait 4 weeks, radiation to try to prevent. And then I also give a lot of high dose steroids perioperatively. So usually that dampens down the activity as well. So then they're usually moderately quiet by the time they get to radiation. And then you hit them again with radiation to really get them to remain quiet. So I hope that's kind of what you were expecting that I would say now.
Sir Vivian, one more question before you move on. Why is radiation contraindicated for those under 35?
So I think the number 35 is a little arbitrary. The reason for avoiding radiation in younger individual, it's also because of secondary cancer. So there's more and more concern about secondary cancer. Now, we don't actually know the true incidence of secondary cancer secondary to radiation, especially when you have to stratify by dose, because all the study look at all comers. And it's really more of a concern, I think, in a developing individual. So post-puberty, I think it really doesn't matter anymore, but all clinical trials are gonna be super, super cautious. So they're gonna err on the side of safety, and that's why they arbitrarily pick 35 as a cutoff. Yeah.
Thank you.
I know from uveitis clinics, to get approval for a biologic, you have to fail other treatments. Is that similar in thyroid disease?
So right now, because the original studies from Europe was failing steroid, so that's the only thing I have to prove. And then also the definition of failing steroid is also ambiguous. So unfortunately, there's so much gray right now in thyroid. The clinician can really push it in any direction they want. So the first patient I put on TOSI, it took a little bit of rigmarole, and it's like rejection, appeal, rejection, appeal, rejection, appeal, and eventually I got it by talking to kind of the people who approve it. So it does take a little bit to set a precedent in a province, but the beauty in Canada is once you set one precedent, the subsequent one become like automatic. I just submit the exact wording, the exact paperwork, the exact stuff, and they were like, okay, approved. And they even like the clinician who's on the other side, because you have to realize the people approving it are doctors too. So the rheumatologist is like calling me up being like, I know nothing about thyroid eye disease. I had to do a major Google search to figure out whether this should be approved or not. It sounds like it should be. And then she even told me, she's like, don't worry, the subsequent will be easier. Just, we'll follow the standard protocol. I'll write a blurb into the kind of their kind of backlog thing so that in subsequent approval will be really easy. So it just takes one person in each province to kind of spearhead it, and then it becomes easier for everyone else. You do have to submit an article. So I had to submit like all the literature search. I have to submit my clinical, notes of progression, et cetera, et cetera.
Just a question for patients who already have like some component of compressive optic neuropathy and then we're treated with radiation. Like, what are the things you would like consider when if you want to differentiate? Is this progression of optic neuropathy, is it related to radiation or just like ingoing compression, or should you like do more radiation? What are the things helpful here?
You guys are asking really amazing questions. So I have an entire section of my talk about my thyroid talks, just talking about optic neuropathy, from definition to follow up to how do you manage it. So the short form of that answer is that optic neuropathy has to be diagnosed, and I'm not a neuro-ophthalmologist, so the neuro-ophthalmologist in the audience, I apologize for my dumb way of thinking about this. To me, it has to be multiple metrics. So it's not a single metrics that would tell me they definitely have optic neuropathy. I rely on Goldman visual field a lot. Now I know that's daunting for people who practice in the community because usually Goldman is only available in academic centers. So I recognize that. The ones that are easy to tell is when they like massive visual field defect. It's like anyone, a first-year resident would know that's optic neuropathy, right? The ones that are hard is, let's say, there's no RAPD. Color is like 13 out of 15. They look really hot, really red, really apoptotic. They say they have some red set. You can't measure anything much more than, 13, 14 on plates. So is that, and then on visual field, they're all over the map because this is the first field. So you get these weird patterns. You're like, what the hell am I looking at, right? And that's real life, right? So the answer to that is, oftentimes it takes a couple of visits for me to definitely tell them in the eye to say, you have optic neuropathy. And because it takes 2 or 3 Goldman visual field before the visual field actually starts to show patterns. So you just have to be prepared for that. And Goldman, I would say, someone who is now trained, a patient who is now trained because they've taken it a couple of times and know how to do the Goldman well, that is definitely by far the most sensitive marker in my book. So progression of visual field on a Goldman, I put way more stock in that than if they had like dropped their color plate by 1 or 2, because it may be just they're not paying attention, they're slept poorly the night before, et cetera, et cetera. So, but I looked at all of them. So RAPD, color plate, checked on every visit, Goldman visual field. Anyone who is high risk of progression, they actually get a Goldman every time they see me. I don't rely on OCT that much because I think we know structural change follows after functional change. So if you're gonna see OCT changes on a patient with, optic neuropathy from thyroid, you're way too late. So I don't even order OCT at all. So to me, it's visual field and clinical exam are the 2 major things. And don't trust the patient. The patient's subjective changes usually not that accurate.
So why do you choose Goldman compared to the static visual field test? Because as you said, it's really hard to
Yeah.
get in a lot of centers.
So I think if you don't have access to the Goldman, a 30-2 is fine. If they're late, you'll pick it up. So the advantage of the Goldman, of course, is full field, right? So I do full field, full threshold, all the different thresholds. So you catch them earlier. So a lot of times I would see color plate changes, maybe a very, very subtle early escape. And by the way, you're not going to see disc edema. To see disc edema on a thyroid patient is really hard. They don't have disc edema. So disc is always normal. But they'll say like a 50% red dissat. So that by that point, they will comment on that. You'll see a normal 30-2. That's the problem. So that's why the Goldman is needed really if you want to pick them up early. Why do I care about picking up early? So I have more time to schedule their surgery. So it makes my life easier. So that's actually really more of a practical reason. Let's say you only have 30-2 and you don't pick it up till it's later. That's fine. It just means that you may not wait 2-3 months to get them into surgery. Maybe you want to do it like within a week or two, and to prevent additional loss of visual field. So it does become permanent at some point. Okay. I'm getting the signal to keep going. Okay, so just I'll do a brief update. I'll kind of skip some of these oncology part because otherwise we will be here past 8:30. So this is just a summary slide of available drugs and what did they treat and what pathology and when did FDA approval come into play. Why do I always put on the date of FDA approval? Because that date is the starting of the clock of when you're actually going to see true clinical outcome. So people who practice in the field where there's always FDA approval coming through, they know to wait a little bit. So the initial trial results is never what is actually seen in real life. So you need to wait another 5 years or so to see actually what actually happens when you treat these outside of clinical trial, both side effect as well as efficacy. So these are the drugs available to us. EGFR mostly is using for SCC. However, you have to see SCC is not on the list of approvals. So it's all off-label use of drug. The only one on label is hedgehog inhibition. 2 drugs in that main category, vismodegib and sonidegib. Pretty similar. It's just whatever one you can get your hands easily on. Vismodegib is the one that I use more just because it's more readily available and easier to get. This is the watershed plot from the landmark study and oncology study. They always do watershed plot because it is about survival. So it's always looking at, survival, et cetera, et cetera. So this is what majority of most targeted therapy, all the plot looks exactly the same, okay? It's all about 2/3, 1/3, which is the magic number in medicine, okay? So 13% progression. When I say 2/3, 1/3, I mean complete response. So 43% overall response rate and 21% complete response by biopsy, okay? I always talk about this because I feel I cannot stress this enough. Vismodegib is not a cytotoxic drug. It does not kill cancer cell. Okay, I'm gonna say that one more time. Vismodegib, hedgehog inhibition, does not kill cancer cell. Now, I just said it's a cancer drug. What does it do? It prevents the cell from being able to proliferate. So it's kind of like you're giving all these cell vasectomies and tubal ligation, so they can't make babies. You still have to get rid of the parents though, or you still have to get the ones that are still there. And the thing that is doing that is your own immune system. Okay, so that's actually what's killing the cancer cell. So what that means is if you go off drug, whatever's remaining that is still alive that your immune system haven't sweep up is gonna regrow. Okay, so that's the one thing that I'm gonna say, be careful when you see patients and you're thinking about, collaborating with someone that you have to watch for regrowth. In order to minimize side effect, this is the most exciting thing about vismodegib is intermittent dosing. It does have side effect. I almost tell my patient, everyone will get it, even though it's not 100%, but I say everyone will get one of these symptoms and it's not mild, it's moderate at best. And the 4 side effect is alopecia, muscle spasm, loss of taste, and weight loss, okay? So intermittent dosing is really trying to help with those side effects so that people can be on the drug longer, more meaningful for those who are metastatic and more meaningful for those who has basal cell Nevo syndrome who may need to be on it for the rest of their life. This is what the drug can do for a basal cell nevus syndrome patient. This is a patient of mine. By the time he got to me, and he's been cut 14 times. He got sent to me specifically for consideration of vismodegib. And yes, I prescribe my own, and yes, I monitor on my own side effects. It's not that hard. It does make it so that your practice become more and more like an internal medicine practice. But it's very rewarding because you're the one who gets to see him when he is happy and he has like no more. So every single, I don't have a pointer. Every single one of these bumps that you see that looks like a pimple that he has, all of them are basal cell. Okay, and you can see he has scars all over his face. He doesn't quite look quote unquote normal. He has a scar underneath his upper lip and nose. So all of those were gone pretty much after being on the drug. So the other thing that's interesting about these targeted therapy is, well, can we use it in other fashion? Just like I talked about thyroid eye disease, can we use it as a neoadjuvant treatment? Now, this topic has come out, I think, a while ago. So to me, it's not so new, but I think literature sort of died on it and discussion around it has died. And partially because we know the answer to some of these questions now. So when you use it in a neoadjuvant fashion, and I told you this is not cytotoxic. So how does the cancer regress? Does the immune cell attack it like cleanly from the outside in? Does it go inside out? Does it go like spotty, like a spray? We don't know. And where do you cut afterwards? Do you still cut the original size? Do you cut what you see? Do you cut nowhere? How do you even control margin? Is frozen section, which is the gold standard for margin control for basal cell, is frozen section still accurate at that point after all these changes that the drugs has made? And how long do you treat people for before you start to cut? Don't know. 2 studies came out, incredibly small number, 8 patients each, one from MD Anderson, one from Europe, looked at this specific question in patients of theirs in neoadjuvant use. Again, off-label, drug is not approved for use in this fashion. And they treated different duration, 6 months versus 14 months, very, very different. And follow-up is also kind of short, 10 months follow-up, 12-month follow-up. And what they saw is pathological complete response, meaning they went back and cut, and there was no cancer there, was 62%. So that's kind of exciting, but sort of the same as what the original study has shown. Now, this is a question that the study did answer. Yes, there is satellite regression. And I'll show you another patient of mine, which kind of defeated the whole purpose of me putting her on a vismodegib at all. So recurrent, multi-recurrent, locally advanced into the medial orbit. I'm not showing you a CT scan here. Dramatic response, right? So if you look at the left and the right, I'm like, wow, maybe there isn't much there now. This is maybe just lid retraction from the cancer having eaten the lid and just cicatricial. I really couldn't see anything definitive that was ulcerative or nodular to think that there's cancer there. Anyway, started cutting into her, and this is when I was in the US, so I had lots of OR time. And it was positive, 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 positive. And it's very, very small foci. I am gonna move M&D. So tiny little foci, okay? Tiny little foci. Like, it is not dramatic, and it's only pathologists, I think, at Cancer Institute will have this kind of patience to get these beautiful frozen section slides. And I think even in Vancouver, my pathologist would kill me if I did this to them. So then it becomes, well, then you just told us bad scenarios of using neoadjuvant, and the patients still end up being basically microscopic everywhere. So what's the point of using neoadjuvant? I'll show another case of mine, which also got put on vismodegib. So this is a patient also with recurrent basal cell, biopsy proven, had previous resection from the forehead, now ends up in the orbit, and has this mass. Let me see if I can get it to play one more time. In the superior orbit that doesn't look too bad, right? So get the first one. Anyways, it was, I don't know if you saw it on the left-hand side. It's like, look pretty neat. It's like a perfect circle. We should be able to treat it and then do a little resection, right? So I actually took him to surgery initially, and then 7 weeks post-op, unfortunately, he regrew. So within 7 weeks, the nice little bump is back, and now with the intracranial extension, okay, along the dura. So he got put on vismodegib against my advice. Actually, I wanted him on immunotherapy, but MedOnc decided to put him on vismodegib. And the argument at the time was that this is predominantly basal cell. It's immunotherapy works slower than vismodegib, so their thought was vismodegib will work faster. Now, the word of caution about this patient, because this is 1 month after vismodegib, is that he had one tiny foci of squamous cell. So on pathology, this was actually a basal squamous, even though it's just one foci. And he got even bigger after 1 month of vismodegib. So the unfortunate sad story about this case is that even though we think adjuvant may work well with some of these cases, if you even have any remote pathology beyond basal, do not use vismodegib. The patient will progress, and that was why I was against vismodegib for him, despite differing opinion. And he ended up with an exenteration, which is what I was trying to avoid, and a big cranial resection. And unfortunately, most recently, this patient actually metastasized. So now he's in a very bad place with, probably drug therapy only. So even though the pathology did say that there was basal cell predominantly, but small foci squamous, okay? I'm gonna skip over the drug side effect in view because I do want to talk about checkpoint blockade. So this is a summary slide of all the other drugs for melanoma. So we talked about basal and squame. So for melanoma, there is a lot more drug therapy available. Now, some of these immunotherapy are being used for basal and for squame as well now that are resistant to other drug therapy. However, by and large, I would say for squame, it is usually just the PD-1 and the CTLA-4 that are being used, and then the rest are still predominantly melanoma. So the checkpoint blockade nowadays, what is more in vogue is actually combination therapy. So no one goes on PD-1, PD-L1 only now. Usually people go on 2-pathway blockade. So you either, and same thing with other drugs. So the BRAF blockade also, no one will go on single BRAF blockade. Now it's always BRAF plus MAC or BRAF plus mTOR. So similarly, now it's a combination of Nivo and Ipi. So Nivo, nivolumab is the PD-L1 and Ipi is the CTLA-4. Now, the two things to know about combination drug is one, toxicity is a lot more severe, especially the CTLA-4 is the one that is more toxic. So sometimes they'll do dose reduction. So even though original clinical trial actually used both at every single infusion point, now they do like a 4-to-1. So 4 Nivo, 1 Ipi kind of thing to try to minimize toxicity. I'll kind of skip over this and just show you the one clinical example. So this is a patient of mine who had metastatic melanoma to the lateral rectus, biopsy proven. And this is after just one cycle, 4 doses, so 3 Nivo, 1 Ipi. And you see the dramatic reduction, and there's now just a tiny nubbin compared to baseline, okay? So you can see pretty dramatic results. And of course, he presented to ophthalmology first. We actually don't know where the primary is. So melanoma, a lot of times, you don't find a primary, you see metastasis first. So he unfortunately presented to resident clinic saying, I have diplopia. Resident sent him for a CT scan. CT scan showed this. Patient got sent to me, got a biopsy, and started on drug. The other thing that is interesting about melanoma is the use of neoadjuvant now. So I talked a little bit about adjuvant use. I talked a little bit about primary use. So now there is more study looking at melanoma specifically, not just head and neck, not just ophthalmology and oculoplastic, but full body melanoma. And they're trying to use 3 doses neoadjuvant before resection. And what they showed is that the neoadjuvant plus adjuvant group actually does better survival, which is something that has never been shown or proven before, compared to adjuvant alone. So why is pre-treating helping people survive longer when pre-treatment is actually meant for surgical resection to be less morbid is also very interesting. So lots of things we actually don't know about. This is the only drug that's approved for cutaneous squamous cell, which is the other big thing that we see in oculoplastic or in ophthalmology. And this is a pharma kind of advertisement, and they always show very, very dramatic response. We always call it the poster child, and you'll see the same patient over and over and over in every advertisement. And just after 6 weeks of a PD-1 alone, dramatic reduction. Now, when you look at the actual watershed plot from the landmark study that led to its approval, exactly the same as what you saw with vismodegib. And I think this is all you will ever expect, 47% objective response rate. The number almost look like they're a carbon copy of each other. Now, the one thing with PD-1 and immunotherapy is that I briefly alluded to the fact that side effect is a lot more severe. What do I mean by severe? Not like vismodegib where I already told you, everyone gets side effect and it's just a topic of managing their side effect. The reason I say this, you have to pause and think about, is because of death. So there has been death because of drug, like directly attributed to drug therapy. So these are not benign. These are not like in a frail patient, I would not put them on immunotherapy for two reasons. One, high risk of death and toxicity. And two, also it doesn't work when the patient is really frail, have no immune system. This actually interacts with the patient's immune system in order to augment it to the simple way to think about it is to trick it into killing the cancer cell. So if you don't have an immune system because you're frail and immunosuppressed, this drug is not going to work. Okay. So I think I'm just gonna skip over that and just kind of summarize how do I think about these drugs, just like how you guys asked me, how do I think about thyroid? So when to consider neoadjuvant use? When it's difficult to have surgical cure. So if I think the surgical resection is going to lead to an exenteration, that's when I start to think about neoadjuvant use in order to avoid an exenteration and try to preserve the eye as much as we can. The other thing is if the patient has multiple recurrences, to me, this is a dirty case. I am not confident when I'm going to cut. How do you know I'm not going to miss a tiny little satellite and then they're going to just recur again? So those are the other cases. I'm like, well, maybe we can use drug therapy to mop things up, but maybe then I have a higher chance that my surgical resection is not going to recur. However, you have to balance using these drugs in the delay of therapy, like the patient I had, which now progressed to the point where he actually was not resectable from a neurosurgical standpoint, not from the eye standpoint. But from a neurosurgical standpoint, it was too extensive for them to say they could get complete cure. And when you think about adjuvant use, it's really a balancing act. It's about toxicity of other therapy like radiation versus drug therapy, and then also balancing that with what am I treating here? Am I treating microscopic residual? Am I treating a positive margin? Am I treating for recurrence? Am I treating for metastasis? Because the drug of choice may be different, duration may be different, dosages may be different, the combination may be different. So I hope I kind of talked a little bit about the two kind of big category that we have major drug therapy for now, thyroid and of course cancer. And then just kind of highlight kind of the nuances. It's not so straightforward as thyroid, it's not dermatologist. It's not you put steroid on everything that's wet. And it's like it's a little bit more nuanced and complicated than that. But it is exciting that at least we now have drug therapy. Now there's another tool in our toolbox. And I think we are only going to see more and more. And I think there, besides IGF-1R, there is also a lot of other pathway because I mentioned thyroid. We don't know the whole mechanism yet. So I think there's going to be other things that people are going to try. Any question?
Vivian, thank you so much. That was a great talk, very comprehensive, very frank and honest. And I think as this area grows, it's exciting because we have new therapies for patients, but we also have to be mindful of some of the drawbacks as you highlighted. And I think we're going to need voices like yours to help guide us in understanding the indications and contraindications for these medications. Question here from Dr.
Drug
Yucel.
company doesn't ask me to speak for them.
Well, and that's why we need voices like yours. What's your experience with the off-label use of adjuvant treatments for conjunctival melanoma?
So, okay, how do I answer this? I am not a believer of using a systemic drug for a local disease. So, orbital disease, we use adjuvant partially because you cannot, in the orbit, you cannot actually get true margins because the fat is like, I always tell residents, it's like you're in those, what do the kids play in those balls, like the pan with the balls in it? Yeah, so it's like that in the orbit. Like there is no margin. Those things are never clean. Like it's just things move around. Like you cannot prove ever a complete resection. But conjunctiva is a different story, right? So conjunctiva, it's a flat surface. It's two-dimensional. It's two-ish dimensional. Like it's not like the orbit. So I think topical and even intralesional chemotherapy works better for a two-dimensional disease than for the orbit. So I don't use adjuvant unless they have nodal metastasis or early nodal metastasis to justify the toxicity of drug therapy to the whole system.
Thank you. And then I'll do one more question for you, Vivian. There's a question here about the contraindicating data that tocilizumab worsens optic nerve damage. And what do you? And the second part is, what do you think about the effect of radiation in the chronic stage of TED for diplopia?
Okay, so I'll answer the second one first, because the first question I don't quite completely understand what they're asking. So radiation for chronic doesn't work. Radiation is the same way. It's just treating inflammation. It dampens down the inflammatory cascade. So 0 point of using radiation for chronic diplopia. That's surgery only. The first question asked about TOSI and optic neuropathy, and TOSI causing optic neuropathy. Is that what it's asking?
Apparently the question is there's some data to suggest it may worse optic neuropathy.
So I think it depends on if you're looking at case series or you're looking at the actual randomized trials. So none of the randomized trial actually saw worsening of optic neuropathy. Now, so I don't think TOSI causes optic neuropathy. I think TOSI doesn't cause radiographic reduction of EOM volume as much as we see. And even in the Montreal data where they show reduction or a reversal of optic neuropathy, when you actually scan them, the muscles are just as large. So I think more likely in those case reports of optic neuropathy with TOSI use, those are patients progressing and where TOSI did not work. So like every drug, all of these drugs are exciting when it works, but the truth is they will never work 100% of the time. So you will always have failure cases, and you just have to prepare yourself and the patient that you never know when you give a drug whether it's going to work or not. And I think that's more likely the scenario. I cannot think of a theoretical justification for why TOSI will cause direct optic neuropathy. In IL-6 in its pathway, there's no way that it can cause a mechanism that makes sense to me.
Great, thank you. Vivian, once again, thank you for that wonderful talk. I think we're going to have you back in a year or two for an update on this area, because I feel like it's going to be rapidly evolving. On behalf of the department, we're so proud to see where you've gone with your career. I'm sure Wai-Ching and John feel the same way, but we're really proud to see your trajectory, and we look forward to having you back. Thank you again for your time with us this week.
Thank you. And shout out to, of course, it's not just Wai-Ching and John, but like Dr. DeAngelis was a major mentor, Dr. Ostreicher,
yes.
Dr. Tucker, yeah. So
Yes,
everyone.
I'm sorry, I'm remiss. I'm biased towards the residency program, but we have an amazing oculoplastics. Dan's there, Nav's on the line as well, and Jamie's here as well. Nancy's wonderful, and you guys obviously inspired Vivian in her residency to go into oculoplastics. So thank you guys as well.
Thank you, guys.
Thank you, everyone.
Thank you for clearing with it.
Jamie, where are you? You're muted.
It's just my sunroom in Toronto.
Oh, okay. It looks exotic.
I'll be down there in a month.
Okay, well, enjoy. Nice to see you.
Yeah, likewise.